Well, thank you, Martin. It's a pleasure to be here. And your quote from Shakespeare is very apropos, because tomorrow night I will see Richard III with Martin Freeman, who many of you know better as Dr. Watson in the fantastic BBC series of Sherlock Holmes. So it's going to be a Shakespeare weekend. It's a real pleasure for me to be here and to talk to you. I know it doesn't sound like it, but I actually grew up in England and did all my education not too far from here, just around the corner of the Royal Free Medical School, where I was a graduate student in anatomy with Don Grieve, one of the really founders of foot and lower extremity biomechanics in the United Kingdom. And so it's somewhat of a homecoming for me, and I'm really delighted to be here. I'm going to talk to you today, there we go, about, there we go. I'm going to talk to you today about new developments in diabetic foot care, and we'll be sharing some more aspects of this with you in the workshop later in the program. So I am presently a professor in the Department of Orthopedics and Sports Medicine at the University of Washington, Seattle. Today I will talk to you about my one passion, that's diabetic foot care, and tomorrow about another, which is running biomechanics. I'm also a principal in Diapedia, which is a research and development company in the States that has pioneered some of the developments that I'll talk to you about, in particular the inclusion of shape on the right and pressure on the left in designing an orthosis to keep a patient with diabetic foot from re-ulcerating. Now, by way of disclosure, I really have already made it that I am a principal in Diapedia, and I'm a co-inventor on a patent that describes the manufacture of insoles through shape and pressure, so you must take that into account and either choose to not believe anything I say or listen and make your own judgment. A few acknowledgements. The work that I shall present has been supported by the National Institutes of Health in the United States. We've had, over a period of several years, 3 separate funding tranches from the NIH do this work. And the National Institute for Diabetes, Digestive and Kidney Diseases has supported the trial that really underpins what I am going to talk to you about. My collaborator for 20 years, Jan Albrecht, is a real partner in this and was the medical director of the Careful Prevention trial. And Tim Hurley, who is in the audience, and you will hear from him later in the day, is the CEO of Diapedia. Now, here's an outline of what I'm going to talk about. I want to start and put into context the growing burden of diabetes in the world, in the United States, and in the UK. I want to talk about the pathway to lower extremity amputation. This will be something that most of you already know. I'll talk about shape-based design, adding plantar pressure to a design. I'll talk about the randomized controlled trial, a little bit about the economics of prevention. So this is a list that no country wants to be on. This is the worldwide burden of diabetes today in blue, and in projected 2035 in red. And the numbers to the right of each bar are the millions of people in each country shown here who have today diabetes and will have in 2035 diabetes. And you can see that it's an absolute worldwide epidemic. 142 million people in China will have diabetes by 2035. And India is going to almost double in their prevalence in the next 20 years or so. Now, the UK at the moment does not appear on this list, mostly because of the population size rather than the prevalence. But let us look at the, excuse me, I must get this sorted out. There we go. These are the nations with the highest prevalence of diabetes in the world. And you can see there are some stunning numbers on here. And let's choose a few in the middle because the South Pacific Islands are very, very small numbers. But let's look at Saudi Arabia, Kuwait, and Qatar. We've got there 1 in 4 people in those states have diabetes. So an absolutely astonishing prevalence. 25% or so of the people, all people in these countries have diabetes. Now, what about the UK? One of the most stunning changes for me to come back after many years is to see the number of obese children. It's just stunning to me how obesity has become a disease of childhood in this country. And of course, as you know, we're seeing more type 2 diabetes in teenagers, and it's a very common and worrying trend because it has tremendous implications for the burden of long-term complications. Because previously, if you got type 2 diabetes at 50, 20 years of complications would bring you to age 70. But if you get type 2 diabetes at 17, then before you're 40, you're going to be at risk for blindness, for heart disease, stroke, and lower extremity amputation. The NIH website, NIH Choices, shows that 1 in 4 children, 1 in 4 adults and 1 in 5 children in the UK have a BMI greater than 30, which is pretty astonishing. And 30 of BMI is the classification, the threshold for obesity. And what is more stunning is that these values have trebled in the last 25 years. So we have seen in the UK a dramatic increase in obesity. And as you know, obesity is the harbinger of diabetes. And these figures from Diabetes UK website show that there is a prevalence of about 5.4%, 5.5% in England, slightly less in Wales, slightly less in Scotland, and less still in Northern Ireland. And in England, the highest prevalence is in northeastern England and the West Midlands. These prevalences do not compete with those in the Gulf states, of course, where they were 25 and 25% compared to 5%, but nonetheless, they imply about, at present, 3 million people in the United Kingdom with diabetes. And you can see that the projections through about 2025 show a linear increase, slightly nonlinear, but basically a linear increase. This disease is going to continue to accumulate and grow in prevalence as we go forward unless something dramatic happens, and that would have to be in terms of societal changes in exercise and dietary patterns, and there's no sign yet that that's really going to happen. So what is the implication of this? In fact, before we do that, let me just show you where you might be heading, because this is a rather worrying map of diabetes prevalence in the United States. And you can see that the numbers here, everything that is white is the present UK prevalence. Everything that's not white is at least up to twice as great as the prevalence in the UK. And you can see the way you have a cluster here in northeast England and the West Midlands, there's a tremendous cluster over the south and southeast coast of the United States of high prevalence. Here you see that every one of these counties that are shown in blue has a prevalence greater than 11% of diabetes. So I hope you're not heading there, but there's every indication that you are. Now, what does this mean, and what are the implications of this for people at risk for foot ulcers in the UK? So if we say that at the present time in the United Kingdom there are approximately 3 million people with diabetes, and very conservatively, let's assume that 10% of them have loss of protective sensation. And so this is a term we define rather loosely, typically based on the touch of a 5.07 monofilament. But the notion here is that you have sensory neuropathy that is sufficient for you to injure your foot without you being aware of the injury. And so if 10%, and that is a very conservative term amount, if 10% of people have loss of protective sensation, then 300,000 people in the UK are at this present moment at risk for a foot ulcer. and that's going to double over the next 15 years. And so there's going to be a huge demand for podiatric diabetic foot care. And certainly the model in the United States has been that podiatry is the profession that steps forward. Orthopedic surgery is really not interested in diabetic foot care. And I can say this from an inside perspective because I'm in an orthopedic department. There's not enough money in it, there's not enough procedures in it. They'd much prefer to be replacing a knee or a hip or doing something that carries high revenue. And so there's a real concentration of foot care amongst the podiatric physicians and surgeons. And this is the group that has really stepped forward as part of a multidisciplinary team very frequently, as Martin was saying, to offer a multifaceted care to people with diabetic foot disease. So that's little vignette one about the state of play in diabetes and really the state of what's to come unless something very drastic happens. This is a classic paper from Diabetes Care in 1980 by the late Roger Pecoraro, after whom the ADA Pecoraro Award is named. And this paper established the role of a skin lesion in the pathway to amputation. And you can see that from baseline neuropathy and deformity, with minor trauma or repetitive trauma causing ulceration, impaired healing, leading to tissue breakdown, gangrene, and all of these events were in the causal chain to amputation. Now, this was somewhat of a theoretical paper at the time, but the gaps have since been filled in to indicate just how and when and how frequently these various events contribute to the pathway. And I want to look at this current pathway, concept of the pathway, and discuss whereabouts we're intervening in the process. So amongst the long-term complications of diabetes is neuropathy. Now, neuropathy is not only sensory, it is motor, it's autonomic, and it's present in children, present in a variable time after the onset of diabetes. But we mainly focus on two components. We focus on the motor neuropathy, which causes muscle atrophy, quite dramatically so. And we focus on the sensory neuropathy, which leads to this loss of protective care. I want to mention in passing the implications of motor neuropathy, because we don't often talk about it. Sika Buss and I published a paper in Diabetes Care of some early MRIs of the intrinsic muscles of the foot. And our goal when we started this was to segment the muscles and chart how the cross-sectional area of the muscles had reduced in people with motor neuropathy. To our great surprise, in many of the patients, there was no intrinsic muscle that could be detected. All we could find was fatty infiltration, and the muscle had completely atrophied because of the motor neuropathy. And as you know, this leads to pathology in the toes and other foot pathologies, but it's quite stunning to see that there's, when you look at these feet at surgery, that there is just a silvery, whitish tissue where there should be muscle. The muscle has atrophied. So the neuropathy then leads to the foot deformity, and these together lead to foot injury, to foot ulcer. If you add, at an early point, concurrent with the neuropathy, ischemia, and so you've got a neuroischemic foot, this makes foot injury much more dangerous. And this can lead to infection and amputation. And so given this pathway, what can podiatry do, and where does podiatry intervene in this pathway to cause a difference? Well, the focus is right here between the recognition of neuropathy and foot deformity as the predisposing factors for progressing in that pathway. At this point, there's a possibility of using orthotic intervention, footwear intervention, and some would say prophylactic surgery and enhanced foot care to prevent progression to the right of the pathway where foot injury, foot ulcer, and amputation can occur. So let's turn briefly to the present state of the art in orthotic foot care for diabetic feet. The mantra to date has really been accommodation, so that in a typical sports biomechanics situation, the podiatrist is really looking to modify and augment the biomechanics of the foot. We're looking at changes in the varus and valgus control of the rear foot and the rear foot to forefoot relationship and the hallux. Whereas in diabetes, it's typically been that what we want to do is provide accommodation for the foot. And the way we've done that is to worship at what I call the foot shape altar. And that is that foot shape is everything. And if we just take a representation of the patient's foot and reproduce it in an orthosis, with perhaps a modification that I'll mention in a moment, that's what we need to do to prevent either ulcer recurrence or primary prevention, prevent the first ulcer in a foot in diabetes. Now, there is a notion implicit here that total contact means equalizing pressure. And that concept is widespread in the literature, that if you provide a total contact, you're going to equalize the pressure. And that simply is not the case. A number of studies have shown that you start with a foot that has peaks of pressure distribution that I'll show you in a moment. You provide total contact. You certainly have attenuated some of the peaks, but you certainly have not equalized the pressure throughout the foot. That doesn't happen. You're still left with areas of high pressure. And the question is, are those areas of high pressure sufficient? Have they been sufficiently attenuated to prevent further tissue damage? So the current method is to capture the shape, either traditionally with a foam box, more recently with a 3D scanner, to pour the mold, and to add perhaps some offloading like a metatarsal pad or a bar by visual judgment as to where it might need to go. And this supplementary offloading, for example, there's a metatarsal bar that you see, a metatarsal pad, that you see here. There have been a number of studies to show that where you place it, as you would expect, radically affects the unloading that you get. And you can see that by small movements that are shown here, just 5 millimeter movements, a number of studies have shown that the offloading changes by between 16 and 82%. And it's very hard visually, without any way of evaluating it, to make an intervention like this and know that you're doing the best for that patient's foot. One of the things we do really badly in diabetic foot care is to prevent a recurrence of a first ulcer. Recurrence rates are extraordinarily high. In some studies, such as those shown here, they are up to 80% after only 3 years. And so if a patient has had a prior plantar ulcer, that is the highest risk factor that they're going to get another one. And it seems that we just haven't worked out how to prevent them from regressing and having a recurrent ulcer. Notice that I'm not putting the attention on primary prevention here, preventing the first ulcer, and that's because in most healthcare systems, it's very difficult to finance primary prevention. The healthcare systems usually argue that our methods of identification of who's at risk are perhaps not adequate to be cost effective. So that, let's take, for example, that we gave everybody who has diabetes enhanced foot care. Then the payers might suggest that that's not an economical provision of foot care, that you have to be applying your resources to a more targeted population. And the way that usually shakes out is that the people who get the care are the people who have already had a plantar ulceration. And so that's where most of the attention has been, and that's where I shall put our attention today. What you see here is a plantar pressure distribution taken from a patient who has elevated forefoot pressures. And we'll talk a little bit about what's the definition of elevated and how much pressure do you need to relieve in a little while. But you can see that this foot is a cavus foot. There is no contact. It's a left foot, and there's no contact in the midfoot area here. There is high pressure under the fifth and first metatarsal heads, and relatively high toe pressures, particularly under the hallux. Now, this is a dynamic pressure distribution, and typically what we do is we capture from that a peak pressure plot, shown here from the same dynamic plot that you just saw. And so we capture here the highest pressure that occurred at every location on the foot at any time during the contact phase. So we're able now to get this snapshot, which provides us that insight that we could not get from just looking at the cast and deciding where we're going to put an intervention in the foot that we think is going to be preventative. Now, we can also look at this in a different way. So this is looking at it from overhead. It's a little easier to see this way because it represents what we're going to do on the orthosis. And so we can capture that, a peak pressure from that looks like this. And the purple pressures are the high pressures, and the green and yellow pressures are the lower pressures. So by capturing such information, we have a roadmap as to what we're going to do inside this patient's shoe to relieve these pressures that are potentially damaging. And the focus that I'm going to have today is on the forefoot, which is where the majority of these lesions occur. So the emerging algorithm, as I'm giving you the pieces of how this fits together, is that we take the shape of the foot, and there you see a three-dimensional scan. We take the pressure that you've seen on the right. We combine these together with provider input so that the clinician has input into a design algorithm which automatically goes into these data and chooses a location for a series of locations for pressure relief. And here you can see a very rather complicated metatarsal bar together with an area of excavation here. It's made from a CAD file by a milling machine, and the final CAM insole, computer-aided manufacturing insole, is made. So it's not enough to have an idea. One has to have some evidence that the product is effective. And I'm going to take a two-stage process here, and first of all say, if you design an insole this way, does it give you improved offloading compared to the conventional design of insoles? But of course, if it provides offloading, that's not the end of the line. The most important thing is, does it prevent reulceration? And so the second question here is, I'm having a little trouble here with there we go. The second question here is, does it lead to improved offloading and fewer plantar ulcers? So first of all, does it offload? And secondly, is it clinically more effective? So the first question was answered in a paper in Diabetes Care that we published in 2008, and we took 20 diabetic patients who in both feet had 70 high pressure regions. We provided them with a true contour orthosis, and we compared them with two commercially available insoles. Now I shall drop this term A5513 because it's a tag that the healthcare system in the US applies to a device that goes in the shoe that Medicare will reimburse. So this is a reimbursable insole that is for patients who have certain qualifications, diabetes, deformity, prior ulcer, and some neuropathy. And we measured in-shoe pressure. The pressures that I have shown you to date are pressures from a flat platform, and we'll show you that platform during the workshop this afternoon. But the true way to know if you're offloading the foot with an insole is to use a pressure insole itself, which is an in-shoe device. So here you see the design. We took an insole shape-based only from company A, shape-based from company B, and a true contour insole. And I should add that the company A and company B insoles were also modified by the clinician to provide visually placed features, pads and bars and depressions. And here's the in-shoe pressure system. On the left you see a very thin insole, about a 1/16 of an inch, between a 1/16 and an 1/8, that has about 100 pressure sensors in it, goes inside the shoe between the patient's foot and the top of the orthosis. And I mentioned that there were a total of 70 regions of interest in these feet in the forefoot. There were 29 at metatarsal head 2, 16 at the lateral metatarsal heads, and 25 under metatarsal head 1. The mean peak pressure at these locations was about 834 kilopascals. Now, 1,000 kilopascals is about 145 psi. So you can see that at these peak pressure locations, there was about 120 pounds per square inch at each of these ulcer locations. And that's the tissue damaging pressures that during barefoot walking were measured at that value. So this raises the question, so how much do you need to reduce this down until you think you're into a zone that's not going to cause tissue damage? And so we've done a study in Sweden where we looked at all the patients in the clinic in Lund, Jan Appelqvist's patient, a very distinguished Swedish diabetologist, and we found that those patients who had remained healed all had pressures less than about 200 kilopascals. And so 200 kilopascals, about a quarter of what the barefoot pressure is, has become the provisional watermark that you have to try and get pressures down below to ensure that the patient is going to stay healed. And so that's the goal of the orthotic intervention. Now this is pressure at every one of the 70 regions in the three different orthoses. And let me lead you through just one of these regions. Let's take one of them. It's region maybe 22 or 23. And if we go up the axis, you see that was the pressure in shape A. It had been reduced from about 800 down to 375. Here in the shape B insole, you can see that just two insoles made on a shape basis were very different. And finally, the peak pressure in the shape and pressure-based insole was down below the magic 200 kilopascal value. And so these are ranked by the highest pressures to the lowest pressures. And you can see that, I'll go back for a moment and show you the full list. You can see that some of these were not reduced. There were about 10, 15 values that just couldn't be brought down using these methods below 200. But the vast majority of them were, and you can see that in almost every case, except 1, 2, 3 there, that the shape and pressure-based insole lowered the pressure the most compared to a shape-only insole. So here are the mean values, and you can see that in the two shape-based insoles here, there was a mean of 246 and 212, and in the shape and pressure-based insole, highly significantly different. It was superior at 67 of the 70 regions. So this is very powerful evidence that when you take an approach where you know the mechanical environment between the foot and the floor going in, because that's what this was based on. We started by measuring the barefoot pressure between a flat surface and the foot. When you use that pressure information to design your insole, you can do a whole lot better than you do with just a shape-only based system. Having shown that offloading is superior, the big challenge then becomes, does improved offloading lead to fewer plantar ulcers? And from a research point of view, this is a hugely greater challenge. The cross-sectional study that I showed you previously was relatively simple to do. You recruit patients, you bring them in, you do the measurements on them, you provide them with 3 insoles. When the insoles are made, you bring them back and you measure the plantar pressure inside the shoes with those insoles, and you're done. But to answer this question is a huge journey. And the only real evidence that is accepted in the literature these days is from what's called a randomized controlled trial. And that is the gold standard of interventions, of testing and intervention. It's been very common in other fields of medicine, but it has been slow to happen in the area of foot biomechanics. And I know that because I am part of a consensus panel for the International Working Group on the Diabetic Foot, where we review all the literature, and we've just done this last week. We started with over 1,000 articles which were identified as being connected to offloading and diabetic foot. And by the time we whittled them down to look for the randomized control trials, believe it or not, in the footwear area, there were only 3 randomized control trials that have been done. And I know why, because these are, Tim didn't used to have this much gray hair, but he does now, because this trial was a tremendous management challenge. You have to recruit patients at different sites, multi-center. You have to track them, you have to follow them through months and months and months of their potential history of ulceration. And so this paper was finally published in July in Diabetes Care, the Journal of the American Diabetes Association, and it describes a head-to-head comparison of shape and pressure with shape over a long period of time. So the patients recruited to this trial, they all had diabetes, they all had loss of protective sensation, they had a history of a submet ulcer that had healed within the previous 4 months. And so, as I mentioned to you, the concentration here is on prevention of the second ulcer or more. All these patients had had at least 1 ulcer. So it was a multi-center randomized trial. 130 subjects were recruited. They all had a history of a diabetic foot ulcer, true contour versus the shape-based only, and there was up to a 15-month follow-up while they wore these different insoles in their daily lives. There were 8 outpatient clinics across the U.S. These were academic medical centers, veterans hospitals that look after Army, Navy, Air Force personnel who have retired, private clinics, all from PIs who are experienced in research. Subjects were truly randomized. The experimenters had no control over what insoles were worn. Now, within the shape-based, 3 manufacturers were used, so it could not be a case of, well, you chose the wrong standard care. We chose 3 types of standard care, and they represent what most patients who have diabetes and foot problems get in the U.S. today. And in each case, these shape-based insoles, the prescribers were encouraged to do other things, and indeed they did. In 59% of the cases, they provided metatarsal pads and bars, and a third of them had other reliefs based on the PI's local judgment. The endpoints, and this is another point in another really big issue in a randomized controlled trial, the investigators are not really allowed to judge whether an endpoint occurs or not because of the possibility of bias. And so this trial had 3 independent, well-known diabetes care providers who took photographs, looked at photographs, and decided whether an endpoint had actually occurred. We used a statistical technique called proportional hazards regression, and we had 2 kinds of endpoints. This first one is very familiar to all of you. Diabetic patients typically live with these as part of their sort of daily foot status. These are non-ulcerative lesions. They're very common. They're typically callous, maybe a little hemorrhage into callus. They are common, they're simple to treat, and they have a low risk of infection, and they're very sort of low-cost events. On the other hand, the endpoint was a full-thickness skin ulcer. This is a high risk of infection, it's high cost, and as we discussed earlier, it's in that pathway to amputation. So here are the results, days on the horizontal axis and percentage of patients surviving without the condition on the vertical axis. And you can see that regardless of the footwear that was prescribed, there was no difference in these minor lesions. So it seems that you're not going to be able to make a difference in these minor non-ulcerative lesions with footwear. But and they were not significantly different, but when you look at ulceration, there was a clear and dramatic difference. The red line is survival with a shape and pressure-based insole. The blue line, is survival with a shape-only insole, and you can see this is significant at 0.007. And in fact, there was a hazard ratio of 3.4 for getting an ulcer if you wear a shape-based only product compared to a shape and pressure-based product. These are high cost, high risk of infection patients, and they are in the pathway to amputation here. It's interesting to look at the timing of the emergence of the difference between these two graphs, and you can see that we could describe the rapid fall of the survival in the shape-based only insoles as an infant mortality, that these start very rapidly. You ulcerate very quickly once you're put into, if you're going to ulcerate, you ulcerate quickly if you're put in a shape-based insole. By 180 days, there was already a significant difference between the two conditions, and you can see there, pretty much thereafter, the two sets of curves were parallel. So it's this critical first 3 to 6 months, in fact, I should say 0 to 6 months, when there's a big difference in the intervention with shape and pressure-based insoles. Just a couple of case studies. Here is a patient who was randomized to a shape-based product. She was entirely healed when she went into it. You can see from her peak pressure display barefoot that she had a very high focal area of pressure underneath the second metatarsal head. These are the shape-based insoles that were personalized for her. It looks as though the practitioner here did indeed attempt to put a metatarsal pad there, and you can see that after only 16 days she had an endpoint of another plantar ulcer. These are, from a mechanical point of view, terrible looking feet. Look at these various focal areas of pressure under the first in the left side, and the first, the second, the fifth, the midfoot in the right side. Here are the shape and pressure-based insoles that were made for this patient, and here are their feet after 492 days. So no endpoint. So these are just two examples taken from the graph that you saw earlier. So the careful prevention trial, as it was called, showed that shape and pressure insoles, which we know unload better, they also are superior in being able to prevent the occurrence of the second ulcer. So just a few words in closing about the economics of prevention, and I'm going to use US dollars here because the UK numbers are a little difficult, at least for me, to get at the present time. But it's been estimated, not just in the US, but from European and US studies, that the healthcare expenses, direct healthcare expenses, that is nothing to do with loss of income, change in family status and so on, but the direct healthcare expenses for a single ulcer are estimated to be on average $17,500 to $27,987. This varies dramatically by geographical location, and my colleagues and I from 5 different places around the world wrote a paper showing that the worst place to have a diabetic foot ulcer is India, where you are likely to be bankrupt. Your family is likely to go bankrupt with a single foot ulcer because of the costs of care, where there is no health insurance. But in Western countries, this is estimated to be the average amount. And we've done a health modeling study, a healthcare economics modeling study, to show that faced with these costs for a single ulcer and the somewhat increased cost to provide a shape and pressure-based true contour insole, it is less costly and more effective to prescribe an insole that's going to prevent an ulcer than to treat the ulcer once it's occurred. That's not surprising to you, but I show this just to say that modeling has shown that to be the case. So in closing, I want to give you a quote from somebody who believes that he is an expert on healthcare economics, saying that all I'm saying is let's take the example of something like diabetes. Right now, if a diabetic patient ends up getting their foot amputated, that's $30,000, $40,000, $50,000. Immediately the surgeon is reimbursed. It does not cost this much, and the surgeon does not get this much reimbursement in the UK, I must say. Well, why not make sure that we're also reimbursing the care that prevents amputation? That will save us money. And that man was Barack Obama. And so it has got down to the point where our politicians are beginning to realize that saving money by prevention is the right thing to do. And not only is it better for the patient, but it is better for the system. So, thank you very much indeed.